Tonight, you notice something in the toilet that stops you cold. It is darker than anything you have seen before, almost black, almost tarry. You stare at it for a moment, feel something cold move through your chest, and then you flush it away and tell yourself it was probably something you ate. Tomorrow morning you wake up and feel a little tired, a little off, but nothing you can really name, and you drink your coffee and get on with your day. Next week, it happens again. Same color, same texture, maybe slightly worse. You consider calling your doctor, but decide to wait a few more days and see if it resolves on its own. Next month, you realize you have lost nearly 10 pounds without trying. Your appetite has been off. You feel full after just a few bites at dinner. There is a dull heaviness just below your breastbone that you keep attributing to stress or bad eating habits or just getting older. And 2 years from now, you are sitting in an oncologist's office listening to a doctor explain staging and treatment options. And somewhere in the back of your mind, you are doing the math, counting backwards through the months, remembering every single moment your body tried to tell you something was wrong, every sign you looked at and chose to explain away. I am Dr. Michael Hayes, board-certified gastroenterologist with 18 years of clinical experience, and I need you to watch every second of what I am about to share with you. Not because I want to frighten you. I have spent nearly 2 decades helping people understand their digestive health, and fear without information is the most useless thing I can offer anyone. What I want to give you is something far more powerful than fear. I want to give you the specific, precise, evidence-based knowledge of exactly what your stomach looks like when it is in serious trouble, what the 4 warning signs are that it sends out before the worst happens, and what each of those signs means in language that is clear enough to act on. Before we go any further, I need to say this plainly. Everything I share in this video is educational content, not personal medical advice. I am not your physician. I have not examined you. The information I am providing is meant to increase your health literacy, to help you have better, more informed conversations with your own doctor, not to replace those conversations. If anything I describe sounds familiar to you today, please contact your healthcare provider as soon as possible. Do not wait. Do not decide it is probably nothing. Make the call. There is a man whose story I want to tell you, and I am going to change his identifying details to protect his privacy, but the clinical reality of what happened to him is entirely accurate. His name was Thomas. He was 53 years old, a truck driver from Tennessee who had spent 3 decades eating on the road, sleeping in his cab, taking care of everyone and everything except himself. Thomas was the kind of man who considered going to the doctor to be something you did when something was visibly broken, not something you did for vague digestive complaints that you could barely describe. He came into my office on a Tuesday afternoon looking almost embarrassed to be there. He told me he had probably been wasting my time and he just wanted to make sure it was nothing serious. And then he described, haltingly at first and then with more detail, as I asked questions, what he had been experiencing for the previous 2 months. Dark stools, black almost, tarry in texture. A smell that was different from anything normal. He had noticed them off and on for about 8 weeks and had told himself it was from the iron supplement his previous doctor had recommended, or from the Pepto-Bismol he kept in his glove compartment for the constant road food indigestion. He had lost about 11 pounds since the previous spring without trying. He had attributed that to being busier than usual, skipping meals, the stress of a difficult route schedule. He was eating less because food just did not appeal the way it used to. And when he did eat, he felt uncomfortably full after just a small amount, which he had attributed to eating too fast or eating too late at night. He had no severe pain, no dramatic vomiting, no obvious bleeding that he had noticed anywhere else. He had 3 of the 4 most critical warning signs of serious upper gastrointestinal pathology, spread across 2 months, each one explained away in isolation, never once connected to the others. I want you to understand something about Thomas before I go any further. He was not an uninformed person. He was not negligent or careless about his life. He was someone who had simply never been taught what those specific signs mean, and in the absence of that knowledge, his brain did exactly what every human brain does. It found the most reassuring available explanation and held on to it, because the alternative required action, and the action required confronting something frightening. That is not a character flaw. That is human nature. And it is also, in Thomas's specific situation, something that genuinely endangered his life. If you are watching this, and something I am describing is pulling at your attention because it sounds familiar, please subscribe to this channel right now. I post evidence-based medical information every single week. Information designed specifically to give you the tools to protect your health before small problems become large ones. Subscribe now and turn on notifications because what I cover next week is just as important as what you are hearing today, and you will want to be here for it. Now, I want you to understand what was actually happening inside Thomas's body, because the moment you understand the biology behind these signs, you will never again dismiss them without knowing what you are choosing to ignore. Your stomach is a muscular, hollow organ sitting in the upper left portion of your abdomen, just below your diaphragm. Its inner surface, the gastric mucosa, is one of the most specialized tissue surfaces in the human body. It produces hydrochloric acid powerful enough to break down proteins, digestive enzymes that continue that breakdown, and a thick protective layer of bicarbonate-rich mucus that prevents the acid from dissolving the very tissue that produces it. Under healthy conditions, the cells making up that inner lining live, do their job, and are replaced by new cells generated from stem cells in specialized structures called gastric glands. The turnover is constant. The renewal is continuous. The system works until it does not. When the gastric mucosa is subjected to chronic insult, and the most common cause worldwide is a bacterial infection called Helicobacter pylori, or H. pylori, that balance begins to break down. H. pylori burrows into the mucus layer, damages the protective barrier, and triggers a persistent inflammatory response that, if left untreated, causes structural changes in the stomach lining over years and sometimes decades. Long-term use of non-steroidal anti-inflammatory drugs like ibuprofen and aspirin is another major disruptive factor. Heavy alcohol use, chronic smoking, a diet high in processed and smoked meats, and genetic predisposition all contribute additional risk. What matters is what happens when the lining is compromised. The gastric mucosa under chronic insult undergoes predictable changes. First comes gastritis, then in a subset of patients gastric atrophy, then intestinal metaplasia, where stomach cells begin resembling intestinal cells, which is a pre-cancerous change. From intestinal metaplasia, some patients progress to dysplasia, and from high-grade dysplasia, the step to carcinoma can be short and sometimes rapid. This entire progression, from healthy mucosa to cancer, takes years, in many cases more than a decade. And throughout most of it, the stomach is not producing symptoms so obvious they demand immediate attention. It is sending quiet, deniable, easy to misread signals: dark stool, weight loss, early fullness, persistent nausea. Comment below right now and tell me honestly, how many months have you been noticing changes in your digestive health that you have been putting off addressing? I read every comment on this channel. You would be surprised how many people realize for the first time while watching a video like this that something they brushed off months ago needs a phone call today. Your comment might be the one that helps someone else in the same situation decide to make that call. Now let me take you through the 4 warning signs with the clinical precision they deserve, because each one has specific characteristics that distinguish a benign cause from something that needs urgent evaluation, and you need to know the difference. The first sign is the one that opened this video: dark, tarry, or bloody stool. I need to be very specific about what we mean here because the difference between types of stool appearance carries clinical information. When blood originates in the upper gastrointestinal tract, meaning the esophagus, the stomach, or the first portion of the small intestine called the duodenum, and that blood moves through the digestive system at normal speed, it gets exposed to stomach acid and digestive enzymes. The hemoglobin in that blood undergoes oxidative conversion to a compound called hematin, which is black. The result is stool that is black, sticky, tar-like in consistency, and has a distinctive, pungent, almost metallic odor that is very different from normal stool. This is called melena, and I want to say this as clearly as I possibly can. Melena is never a normal variant. It is not caused by something you ate unless you consumed large quantities of iron supplements, bismuth-containing antacids, or very large amounts of dark foods like black licorice or beets, none of which produce the same texture or odor. True melena means there is active bleeding somewhere in your upper digestive tract. That bleeding could be from a peptic ulcer, from erosive gastritis, from esophageal varices, or yes, from a tumor in the stomach lining. All of those require medical evaluation. None of them get better with time and wishful thinking. A different presentation involves bright red blood in the stool or on the toilet paper. This type of bleeding, called hematochezia, typically indicates a source lower in the digestive tract, such as hemorrhoids, which are the most common cause and usually benign, anal fissures, diverticular disease, inflammatory bowel conditions, or colon pathology. However, bright red blood that is mixed into the stool itself, rather than simply coating the outside of it, is more concerning and warrants evaluation. And a third presentation involves maroon or dark wine-colored blood in the stool, which can indicate significant bleeding from the middle portion of the digestive tract or very rapid bleeding from an upper source. And this is always a situation requiring urgent evaluation. When you see any of these presentations, and especially when you see true melena, the correct response is to call your physician that same day and describe what you are seeing using clear, specific language. Not minimized language, not apologetic language. Clear, factual description, the color, the consistency, how long it has been occurring, and how frequently. If you are seeing large quantities of blood, if you feel dizzy or lightheaded, if your heart is racing, if you have fainted or nearly fainted, do not call your doctor's office. Call 911 immediately. The second warning sign is unexplained weight loss, and I want to define that term precisely because there is an important distinction between weight that drops because you changed your habits and weight that drops when your habits have not meaningfully changed. When we say unexplained weight loss in a clinical context, we mean the loss of 10 or more pounds over a period of 6 to 12 months without intentional caloric restriction, without a significant increase in physical activity, and without another obvious explanation like a new medication or a known medical condition that causes weight loss. This kind of weight loss, the weight that simply leaves without permission, is one of the most consistent red flags in all of medicine. It appears in early presentations of many serious conditions, and in the context of gastrointestinal pathology specifically, it is particularly significant. Here is the biological reason. When abnormal cell growth is occurring in the stomach, the body's immune surveillance system mounts a chronic inflammatory response that carries substantial metabolic costs. The tumor itself is a metabolically active structure that consumes glucose and nutrients at a high rate. The stomach's altered function reduces the efficiency of nutrient extraction from food. Appetite signaling becomes disrupted, meaning the person feels less hungry than they should, often without fully registering this as a significant change because the decline is gradual. And in many cases, eating has become subtly associated with discomfort, with early fullness, with nausea, so the person unconsciously begins eating less without deciding to do so. The weight drops by 2 pounds 1 month, 3 pounds the next, another 2 the month after that. By the time the total reaches 11 or 12 pounds, it has been happening so gradually that the person often genuinely cannot identify when it started. If you have stepped on a scale recently and noticed that you weigh 10 or more pounds less than you did a year ago without trying to lose that weight, that is a symptom. That is data. That is your body telling you that its internal resource management is being disrupted by something, and that something needs to be identified. The third warning sign is the combination of early satiety and upper abdominal discomfort. Early satiety is a medical term for feeling uncomfortably full after eating a much smaller amount of of food than you would normally eat. Not the pleasant, satisfied fullness of a good meal, but the sudden, pressing, almost nauseating sensation of being full after just a few bites, to a degree that makes continuing to eat feel physically impossible. This sensation happens because a tumor growing within the wall of the stomach, or extensive inflammation and structural change in the gastric mucosa, reduces the stomach's ability to distend and accommodate a normal-sized meal. Under healthy conditions, your stomach can expand from roughly the size of a fist when empty to hold somewhere between 1 and 1.5 liters of food and liquid when full. The wall is designed to stretch. The muscle layers are designed to accommodate that expansion and then contract rhythmically to move food forward into the small intestine. When that wall has been invaded by abnormal tissue, or when extensive scarring and structural change has compromised its elasticity, the stomach signals satiety far earlier than it should. This sign is one of the ones that patients most consistently describe in retrospect as having been present for months before diagnosis. It gets attributed to eating too fast, to stress causing tension in the stomach, to acid reflux, to simply having a smaller appetite as one gets older. None of those explanations are wrong in every context, but when early satiety is persistent, when it has been present for weeks and is not improving, when it is occurring in someone who has also noticed weight loss or dark stools, it is not a minor inconvenience. It is a warning. Accompanying early satiety in many patients with upper gastrointestinal pathology is a persistent dull discomfort, pressure, or heaviness in the epigastric region, which is the area just below the breastbone and between the lower ribs. I want to be very clear about what this does and does not feel like, because this is the sign most frequently confused with simple acid reflux or indigestion. It is typically not sharp or stabbing. It is typically not severe enough to stop you in your tracks. It is a constant, low-grade presence. A feeling that something is sitting in the middle of your abdomen that cannot be relieved by antacids, that does not fully resolve between meals, that is there when you wake up in the morning and there when you go to bed at night. The kind of discomfort that a person learns to work around, to live with, to mention in passing without giving it the weight it deserves. The kind of discomfort that, in combination with the other 3 signs, means you need an endoscopy. The 4th warning sign is persistent nausea, with the critical escalation of vomiting that contains blood or coffee ground material. Nausea as a standalone symptom is, as you know, extraordinarily common. If abnormal tissue is found, biopsies are taken during the same procedure and sent to pathology, with results typically available within 3 to 5 days. As someone who has performed this procedure thousands of times across my career, I can tell you with complete conviction, the discomfort is minimal and temporary. The peace of mind, or in cases where something is found, the critical head start on treatment, is incalculable. Do not let fear of the procedure delay your evaluation. The procedure is not the threat. The delay is the threat. Gastric cancer, when identified at its earliest stage, stage 1, meaning the abnormal tissue is confined to the innermost layers of the stomach wall and has not spread to regional lymph nodes or distant sites, carries a 5-year survival rate of approximately 90 to 95%. Those are extraordinary numbers. They are better than most people expect when they hear the word cancer. Stage 2 disease, involving deeper invasion or limited regional lymph node involvement but no distant spread, continues to carry significant survival rates, typically in the 60 to 75% range. The challenge is that in the United States, the majority of gastric cancers are diagnosed at stage 3 or stage 4. Not because the signs were absent earlier, they almost always were present, but because the knowledge of what those signs mean was not present in the person experiencing them. The median time between first symptom and diagnosis in the patients I have seen across my career is between 6 and 12 months. 6 to 12 months of warning signs. 6 to 12 months of missed opportunities to intervene at an earlier, more treatable stage. Thomas underwent an upper endoscopy the morning after his appointment with me. I found a mass in the posterior wall of his stomach. Biopsies confirmed gastric adenocarcinoma. Staging placed him at stage 2. He underwent surgical resection followed by adjuvant chemotherapy, and at his most recent follow-up was doing well, working reduced hours, spending more time with his daughter who had first noticed he looked tired and had not stopped asking about it until he made the appointment. He told me that he had been so close to not coming in at all, that he had fully intended to give it another week when his daughter called him on a Sunday evening and told him plainly she was not going to stop asking. Think about what that means. The margin between Thomas's outcome and a significantly worse one was one persistent phone call from a daughter who loved her father. You do not need to wait for that call. You can make the decision right now, watching this video, that the signs your body sends deserve investigation, that your presence in the lives of people who need you is worth more than the mild inconvenience of an appointment. That knowing is better than not knowing, even when knowing is frightening, because knowing gives you options that not knowing takes away. Before I close, I need to give you a clear, unambiguous list of the symptoms that require emergency response right now. Not a call to your doctor's office, not an appointment next week, but 911 or immediate transport to an emergency room. If you are vomiting blood or dark material that looks like coffee grounds, call 911. If you have passed large amounts of dark blood from the rectum and you feel dizzy or faint, call 911. If you have severe abdominal pain that came on suddenly and is the worst you have ever felt, call 911. If your heart is racing and you feel weak and you have been experiencing any of the 4 warning signs we discussed, call 911. If you have developed sudden difficulty swallowing that is making it impossible to eat or drink, seek emergency care immediately. If you have noticed yellowing of your skin or the whites of your eyes alongside any of the other symptoms described today, that indicates potential liver involvement and requires urgent evaluation today, not next week. For all other presentations, for the dark stools that are concerning but not causing acute distress, for the weight loss and early satiety and persistent nausea that have been building over weeks, the correct response is to call your physician today, describe your symptoms clearly and completely, and advocate for yourself to be seen promptly. The information I have given you today is the information that converts these signs from deniable inconveniences into actionable data. Use it. And please, once more before we close, if you are currently on any medication, including over-the-counter antacids, NSAIDs, or any prescription treatment for gastrointestinal conditions, do not make any changes to those medications without consulting your physician first. The lifestyle and awareness information I share is meant to complement professional medical care, not to substitute for it. Individual circumstances vary enormously, and your physician's guidance based on your specific history, examination, and test results is irreplaceable. You watched this entire video. That tells me something important about you. You take your health seriously enough to invest the time to understand it. That kind of engagement with your own biology is genuinely protective. It is the difference between catching something early and finding out too late. And right now, in the next 60 seconds before you move on to the next thing in your day, I need you to do 4 specific things that each take about 10 seconds, and that collectively could make a real difference. Like this video right now, because that single action helps the algorithm show this information to someone else who is noticing signs they have been dismissing, someone who needs this information as much as you did. Subscribe to this channel if you have not already, because I post new medical information every week, and there are more critical topics about digestive health coming in the weeks ahead that you will want to hear. Share this video with one person in your life, one family member, one friend, one colleague who has mentioned stomach issues, unusual bathroom changes, unexplained weight loss, anything that echoes what we discussed today. That share takes 5 seconds and could be the most important thing you do for someone you love this week. And comment below with one sentence. Tell me what you are going to do differently after watching this, whether that is calling your doctor tomorrow, paying closer attention to changes you have been dismissing, or simply sharing this video. Write it in the comments. Public commitment creates accountability, and your comment might be the one that convinces someone else reading it to take their own health seriously. Thank you for being here. Thank you for watching to the very end. Now pick up your phone,